Welcome. We're just waiting for one more minute. Oh, no more attendees allowed, it says.
Yeah, I just got that message too. I'm wondering.
The limit for GoToMeeting is 25, and that's typically, or it depends on your your subscription. Yeah, it could be 25 or 50. So.
Okay.
My apologies, everyone. I thought we booked the line or the one that had 100 attendees. So let me just. Sorry about that.
Yeah, I think
I can log off.
We've had about 4 or 5 now notifications of people trying to join.
Yeah. So maybe if top people don't mind logging off the actual to allow the others, and then that might create some room if that's okay with whoever other than Lori. And that's fine. I've logged off. Thanks.
I'll log off too, Carrie.
I have logged off as well, Carrie. Thank you so much. That's great, and that will allow others. All right, it's 5 after, so let's begin. For those of you that just joined, I wonder if you would kindly mute your phone in the way that you can with your phone. And if you can't find that mute button, then feel free to use the *6 to mute and *6 to unmute. It can be a little bit distracting because it will tell you if you're muted or unmuted. And why don't we begin? I'll start with making quick introductions. So I'm Carrie Remington with Toward Optimized Practice. I'm an improvement advisor, and very pleased to have so many people join us. There's a lot of passion for this program in the province, and we have people participating from all over the province. I wanted to introduce as well Lori Choma from Toward Optimized Practice. She is our EMR advisor, so if we have questions around the EMR, she is with us. Say hello.
Hi, Carrie. Thank you very much. I'll just add in a couple of other pieces. I'm going to be tag teaming on the technical side with Carrie today. And I just wanted to point out 2 things about this webinar. First, that this webinar is being recorded, just so everyone is aware of that. And of course, we'd love to have your questions throughout the webinar. So please feel free, if there are questions, to let us know as we're going along. Alternately, if you don't feel comfortable chatting with us, there is the chat function on your GoToMeeting control panel where you can type a message, and I will be monitoring that as we go through, so we can address questions that way as well. So I will pass it back to you, Carrie.
Thanks, Lori. And we also have Kylie Kidd-Wagner, who's our content management specialist, joining us. So if we have questions around timelines, when things are going to be changed, so instructions around the Alberta Screening and Prevention, anything like that, and the fabulous tools that you've already received, that comes from Kylie's group. And then people who are in the province who don't know Lori and I, because we're Southern girls, you likely will know Sue, Sandy, June, or Lori DeBoer, who are your improvement facilitators, and then, of course, Neil and Barb, who are EMR supports on the northern side of the province. And we hear some of their voices on the line today, and if you don't hear their voice, you know where to reach them. They're everywhere. So let's begin. So thanks for joining us. Again, the goal of today is just to do a very quick PowerPoint presentation with leaving plenty of time for questions. So let's start with a quick review on Alberta Screening and Prevention and where it came from. Started in 2013. And there's been a lot of passion in the province with this program. And of course, PCNs play an important role in implementing ASAP. And so many of the people on the line today are PCN supports, either they're improvement facilitators or panel managers or EMR supports or many other parts of the puzzle. And so we're grateful to you for your passion. We're grateful to the PCNs for their passion around this program. And it all started with Alberta. This is an Alberta program, as you know, and we do have specialists and GPs and other primary care stakeholders that help us decide in Alberta what are the most important maneuvers, and they also help us keep current as new guidelines change. They allow us to keep current with those new guidelines and new recommendations, and so that's the purpose and reason why we're now revising our screening maneuvers menu for adults in 2016. It's to align with the new research and guidelines that have been released. And so let's just go through that now. And we'll just take questions whenever you have it. And so for blood pressure, you can see age 18 has stayed the same. The interval for that is, screening interval for that is once a year. And height, again, for over 18 is at least once a lifetime. Now, weight has changed. For those over 18, it used to be annually, and it has moved to 3 years now. So that has a little star there for to note that that has changed. Exercise and tobacco have remained the same. No new research on that for changing the interval. Same thing with flu. So all of those have remained the same. Mammography has stayed the same as far as it is still every 2 years. But what has changed is when we had our previous maneuver list, we were waiting for some evidence to come in around the upper threshold of age. And if you recall, our upper threshold of age was 69 years old, and now it has been expanded to include those up to 74 years old. So the interval is the same, but it now is from 50 to 74. Colorectal screening has remained the same. So you'll see that the age for that is 50 to 74, and FIT is every 2 years. FlexSig is every 5 years, or colonoscopy every 10 years, depending on what the clinicians decide and where they want to go with this patient. So that's all remained the same, so not to worry around changes there. PAP has changed, and it's to reflect the new guidelines that have been released. And we'll talk a little bit about the changes in more detail in another slide, but I just wanted to bring your attention here that the PAP tests are recommended between age 25 and 69 every 3 years. It's optional between 21 and 24. And under 21, this is the first time that we've seen in a screening maneuver list of a do not do, and it's recommended that PAPs are not done under the age of 21, and we'll talk a little bit further about why that changed. Lipids have, the ages have not changed for male and female, but the interval has. You might notice, for those that have memorized the previous one, that it's now moved from every 3 years to 5 years. We're using the upper threshold that's recommended. And cardiovascular risk reflects the same thing, that the threshold, again, the ages have stayed the same, but that it's moved from 3 years to 5 years. And the same thing with diabetes. If you recall, it's to do a screening maneuver for adults. You choose one of a fasting glucose, a hemoglobin A1C, or you can use the diabetes risk calculator. So those people who fit in that category, you would do that every 5 years instead of every 3 years. Now, there was something for those people who have memorized the last maneuver list, is you probably noticed there was something missing. And that's the alcohol assessment. So again, we tried to keep current with research. And there was some interesting new research. And for those of you that want to learn more about this, you can go on to the Alberta College of Family Physicians. they have a great article that was released on the new research in March of 2015, or you can go onto our website. For those people that received the update from TOP directly, there is a link in your document for frequently asked questions that you can click on to get that tool. It's a tool for family practice. For those people that are unfamiliar with the Alberta College of Family Physicians, of course, it represents 4,000 family physicians in Alberta. So they, based on their tool and their recommendation and research, we no longer recommend the alcohol assessment maneuver. Now, having said that, it doesn't mean that you can't do it. It from now on will be an optional maneuver for current people who are currently enrolled in Alberta Screening and Prevention, and for future ones, new ones that are going to be enrolling in Alberta Screening and Prevention. It can be optional. You can do it. But I just wanted to give you a little bit of background of why we did not include it in this year's Alberta Screening and Prevention maneuver list. And that is when the Alberta College of Family Physicians gave us the tool around the research that's being done for this, is that they noticed that in primary care, you really can only reduce drinking levels in patients in about 1 in 10 adults over the course of 12 months. So it is possible to help people through brief intervention that happens in primary care. Brief intervention may reduce 1 in 10 adults who excessively drink. So that's good. However, that brief intervention actually had no improvement on mortality and morbidity. So, of course, we know mortality is alcohol is linked to death, and morbidity is alcohol's linked to quality of life. And so, in fact, your efforts could reduce 1 person in 10, but in fact, it doesn't improve their mortality or their morbidity. And in fact, when they looked at how many people you may have to do brief interventions with, there's about 15% of Canadian adults that engage in problem drinking. And in an average practice, that would take over 40 hours a year to do so, reducing that 1 patient in 10. And so the evidence was just not strong enough. It might actually create a burden on primary care. However, we know that people may have a passion in this area, and so that's why we still wanted to keep that optional. So I said I would chat a little bit more about PATH and why things changed the way they did. For those people and those PCNs that are already actively participating in Choosing Wisely Alberta, you'll know of this program. For those that don't know it yet, it comes from Choosing Wisely Canada. We've adopted some of those principles, and it's really about doing the right tests on the right people at the right time. And so we just wanted to let you know that this PAP recommendation for the maneuver list is completely aligned with Choosing Wisely Alberta, and that piece of what not to do, which is do not do a PAP test for women under 21, is aligned with Choosing Wisely Alberta and Choosing Wisely Canada. So I just wanted to share a little bit more information about that.
Need a light, please.
Oh, so those who are not on mute, I'll just have you mute. We just heard you speak there for a second. So those people that are curious, there is a PAP guideline in detail on our website. There's all kinds of tools. So the actual guideline is on our website. There's tips, so quick, short tips and frequently asked questions. So feel free to refer to that if you feel like you really want to get into more details. But I will share with you that under 21 was not recommended, and it aligns with the evidence that, in fact, the harms outweigh the benefits. And so it's the first time we see a do not screen under 21. Between 24 and 21, or 21 and 24, pardon me, their evidence was not strong enough to make a recommendation. So there were a lot of things that would be prudent to start screening and a lot of things that were not prudent. And so we felt that we could not give a recommendation between 21 and 24. And so that we're advising women in that age group to have a good discussion with their physicians and providers in that age category. And for those physicians and providers that are on the line, again, really good documents on the top website for you when you're trying to help women between or advise women between 21 and 24. And then again, 25 between 69, we do have a recommendation, or rather I should say the key opinion leaders in Alberta had a recommendation that you do the screening every 3 years. And it's no longer the days of the past where you would have annual tests and then 3 normals would allow you to move to that 3-year interval. It's really you start at 3 years from now on. And so I'm just going to stop there for anyone who might have comments or questions before we move on. And if you're on *6, you just need to unmute your phone by using *6, or I'll ask Lori if anybody has asked any questions on our chat.
Hi, Carrie. Yep, we just, oh, no, sorry. False start. Never mind, Carrie.
Okay.
This is West Grove. We have a question in regards to the PAPs.
Sure. Hi.
Hi there. So if a patient has an abnormal PAP and is going for colposcopy, are you still recommending annual review?
Yes. So this maneuver list, of course, is the management of recommendations that pertain to asymptomatic women. And I was just reviewing our guidelines that we have on our website for the management of abnormal PAPs, and it actually has very well outlined what to do between under 24 rather, 25 and 29, those over 30 for each one of the conditions. So atypical squamous cells, undetermined low grade, and so on. And so I'm just wondering if I don't want to skirt your question, but it's really well outlined, and you may find some interesting details there, because under 24, you would do every 12 months, and between 25 and 29, every 6 months. So there's a couple of things to finesse in the guideline, and so I'm wondering if it's acceptable answer to have you go right into the guideline for that.
Yep, no, that's fine. Thank you.
You're welcome. Any other questions? And we'll keep going. Thank you for the question.
Hi, Carrie.
Hi.
Hi, just real quick, it's Cindy here.
Hi.
Hi. Just a question, and I just did ask Lori, but clinics already set up with the rules and maneuvers from 2013.
Right.
So I would go in and talk to those doctors first about if they agree with the new maneuvers and if they want to change them?
Yeah, and actually it's a really good question because there is a process for sure. And if you allow me, Cindy, I think everybody might have that question, and there's a good slide that prompts us to talk about that. So I'll just do want to answer that because I also help clinics too, and I'm involved in sort of giving my tips and tricks around what to do now. So thanks, and I know you're with a large group at Calgary West Central, so let's move on. Let's do that.
Okay, perfect.
I thank you for that question because it's an important one. So I just wanted to share with the group then that many of you have seen this graphic, and it's a graphic that is really marching across the province around the patient's medical home and the 8 elements that clinics or medical homes really strive to have good skills in those 8 elements. And what I love about Alberta Screening and Prevention is that it really does help build capacity both in clinics and PCNs in those elements. You can really see that those people that are working with ASAP, you can see that you really get good in panel and continuity, and you're learning for capacity for improvement, and it involves team-based care. And of course, organized evidence-based care, which is what we're talking about today, is all the evidence around it, and patient-centered interaction. So it really does a lovely job about aligning the medical home elements and strengthening that. For those people that have heard the term Schedule B and the arrangement between PCNs and Alberta Health, this, of course, will now be one of the 8 system-level indicators. Alberta Screening and Prevention will be one of the 8 indicators, and so this work will be even more interesting and have a lot more, passion around it, if I could say that. We talked a lot about some of the things that have changed in Alberta Screening and Prevention, but I just wanted to address some of the things that really haven't changed, and that is that Alberta Screening and Prevention is still has scientific advisory committees, and that's why the changes. We use those committees heavily to guide us on the evidence. It is evidence-based, and it still sticks with the philosophy. Primary care is a very busy area of the system, and so we want to make sure that we're able to guide you in the most important areas that affect most of the people most of the time. And you can see with alcohol, we are very conscious about balancing the impact and practicality in primary care settings. And of course, it's not an exclusive set of screening maneuvers. There's lots of passion in the province for other things that people want to screen, and just go for it. Those maneuvers are there to help represent the bulk of mortality in a practice, about 75% of mortality. And so it's a great start, and if you have a passion above and beyond it, just go for it. We will continue to offer this as a toward optimized practice program, and so we do training in an improvement facilitator around ASAP in our facilitator training. Continue to have development sessions, panel development sessions. Our EMR team you know and love, and we and the Improvement Advisor team are still supporting this, and we are continuing to provide tools and resources on our website when you go in and click on the ASAP tab. So those will be all updated, and of course, Kylie and her team work heavily in that area. So to Cindy's question around now what? What do we do if we are a new clinic, and what do we do if so we haven't started yet, or we have started, so we're existing participants in ASAP. So the new participants, they'll begin to use the new menu, and they'll begin to use the new EMR templates, which will vary by vendor, and I will have Lori chat about that in a minute. And the new chart review instructions, and I'll have maybe Kylie chime in about that and the timeline for that. Existing participants, of course, to Cindy's question around what do we do? So for those people who are clinics on the line, we would ask you to connect with your improvement facilitator that is provided to you through your PCN that you work with now and love now, and they'll guide you through the process. For those people on the line who are improvement facilitators, let's talk about it. Yes, you will have to have a discussion with clinics about the updates, and to Cindy's point, bringing the updates to the attention of the practitioners, letting them know that there's certain intervals that have changed, and certain age groups that have changed, and certain recommendations that have changed. And of course, they're based on clinical practice guidelines, and physicians are always the captain of their own ship, and they can choose to use those existing recommendations or do something slightly different. It is their choice. And then we would recommend, if you're an improvement facilitator, to develop a plan around now what should we do? Because there are EMR templates that people are using, and of course they do vary by vendor as mentioned. And the rules and reminders have the old intervals. So those people that are using rules, reminders, flags, that type of thing in their EMR will have to change those intervals, let's say for diabetes, from every 3 years to every 5 years. And those people who are doing chart reviews, I'm just going to put a pause on that for a minute, and we'll chat about that in a second. But I'll have Lori chime in around the EMR piece here.
Sure, thanks, Carrie. So the greatest impact is actually not that large. It's for users of the MicroQuest HealthQuest product because they did push out a template that includes some of the age, I believe the age ranges and perhaps the interval ranges on them. So one by one, those clinics who are on HealthQuest are going to need to contact HealthQuest directly and request an update when they're ready for that updated sheet. So HealthQuest, the vendors have all been aware of the changes since March. So they are aware, and HealthQuest specifically is prepared to make that change. There are no other vendors in the province who pushed out a template that includes any age ranges or time intervals. So the rest of that, to the question that Cindy asked, have all been built at the clinic level. So as Carrie said, because they've been set at the practice level, they'll be changed at the practice level and in conjunction with the clinic. So your rules in Wolf, your goals in MedAccess, your reminders, etc. in Practice Solution, and on it goes, will all be edited at the practice level. And of course, the top guides can guide those clinics. And currently, through the summer, the top EMR tip sheets are being edited and will have the current ASAP template changes included in them.
Lori, I wonder if you might speak to that here. So this is a new tool for anybody who hasn't seen it yet. I really do like this tool. And so for those people that are used to seeing the maneuver list, when you see the new maneuver list and you flip it over, on the back, it still has some practice points, as short practice points, which are great. There used to be quite a large document, though, that expanded those practice points. This tool that you see on the screen has replaced it. And I really do like it because it has sort of some process tips and some EMR tips and some practical implementation things to consider when you're a team member. And that's on our website. And if you're having trouble finding it, reach out to your improvement advisor. Any comments on this, Lori, regarding the EMR?
No, just that there's some general EMR agnostic tips on there. So it's nothing that is EMR specific, but that just gives some general directions for clinics to consider for each of the maneuvers when entering data or when trying to extract the data.
And so it doesn't matter what EMR you're on, this is a general one, and then of course the top team will be updating the actual EMR specific to that particular platform for you. Right, Lori?
Yep, that's correct.
Okay, so let's look at that. Let's look at some timelines, and I might engage Kylie on this too because you're so active in this work. So those of you that are on the line, you may have received, as I mentioned, the frequently asked question tool. I really like it. I use it myself, and it's developed for Improvement Facilitators. It gives you a quick background on what's new and why. It helps helps expand through that process considerations that we just measurement considerations. To chat about that. So those people that have already done a chart review, if you'll notice, some of those intervals are 3-year intervals. And then when you go to do a follow-up chart review or sustainability chart reviews, those intervals have moved to 5 years. Now, I've had a clinic, and I've experienced this myself too. So those clinics will have an improvement already, maybe without doing the work, because of just that interval has been changed from 3 years to 5 years. And so that's just something to keep in mind, that will happen, and it's just part of that changeover from the old maneuver list to the new maneuver list. I'll have Kylie chime in here because she's working very, very hard. The updated chart review tools, the super form, will be available in July, and so we'll have some updated recommendations for that. And we have some interim chart review instructions now, but we'll have the new chart review instructions the third or fourth week. I'll just pause for a minute, Kylie, if you want to chime in, since this is your work and you have probably lots of insight that you might want to share with this group around that.
Yeah, thanks, Carrie. So, as Carrie mentioned, we will be updating the chart review instructions, any supporting documentation to align with the updated maneuvers menu. In particular, the super form or the chart review tool that you guys take out to clinics to conduct the chart reviews, that is going to be updated with all the new intervals, the changes to PAP as well. And that will be released, our hope is next week, actually, the second week of July. It will be launched along with all of those accompanying resources. So that means it will be available on our website, and a notification is going to be pushed out to everyone to let them know that it is now available and that you can access it for new users. As for existing users, we do have a plan in place to start migrating the files we have on hand. So the people who have sent in their super forms to Jeanette, we're going to be taking those, updating them in batches and sending them back out to you guys so you have the newest one on hand when you go out to do your next chart review. So a detailed description of the process will be sent out next week to let you know what the process will be. For those who will be conducting chart reviews in the next few weeks, we ask that you just let us know and put your hand up so that we can migrate your file a little bit sooner and get it out to you. So that's in a nutshell. So basically, you'll hear more next week and receive more details and access to all of the updated resources around measurement with the updates in respect to the updates to the menu.
Okay, excellent, and thanks, Kylie. And again, if you feel pressure because you're doing something sooner than that, don't feel pressured. Just reach out to us and we'll help you. And you can see that the last point here around the EMR tip sheets and related resources, Lori spoke to, and of course, working hard in the Alberta peer-to-peer EMR network program. And if you haven't participated in something like that, it's an excellent program led by physician peers and clinic peers, and your improvement advisor can certainly help you around when those are being offered. So in closing, let's talk a little bit about what we've been seeing. So you've been sending those chart reviews faithfully into Jeanette, and we've been aggregating the results around ASAP, and it's looking really amazing. There's well over 680 doctors that have formally enrolled, and it doesn't even count the hundreds of doctors that we know have not formally enrolled. Many PCNs are working very, very hard. All of you on the phone working very hard and have a passion around Alberta screening and prevention, and perhaps working with some clinics that are not formally enrolled doing chart reviews, but still doing the work through their EMR and through their team. So it doesn't reflect that, but we have 32 out of the 42 PCNs enrolled, and it represents 71% of the PCNs, so people are really going for it. And we've had enrollment in the first quarter of 2006 was the highest enrollment we've seen in over a year. So it's still going strong. It's been interesting to see the maneuver selection. On average, 10 maneuvers have been chosen, but we do have providers selecting between 5 and 12 maneuvers, and 3/4 of them are choosing 9 or more, and over 50% are choosing all 12. So people are liking the work. This is their work, and they're really going for it. You can see that 17% there represents an overall improvement for all the maneuvers, but certainly some maneuvers have less room to grow. So blood pressure, a lot of people are doing a good job with that, and so there's less room to grow versus, let's say, flu vaccine, where there's lots of room to grow. CV risk is a challenging one because many of the EMRs are not that great in calculating it, so it's been a challenge for teams, but CV risk has doubled the number of patients being screened, even though it's only sitting at about 30% screening rate. So it's been interesting to look at the different maneuvers and how well they're being used, and so really congratulations. Look at all the improvement facilitators. When you look at 94 plus improvement facilitators are doing this work, so really building that capacity, and so congratulations on your success, and it's working, and keep going. So we'll pause again for any questions or thoughts or comments, anything we didn't address that you were hoping we would, and I'll bring it back to Lori to see if anybody has asked privately on the chat as well.
No, Carrie, no questions have come through on the web chat.
Okay, so I'll just open it up to the group. If there's any questions, we'll just wait for a few minutes, and if not, we'll let you carry on your day.
Hi, Carrie, Cindy again.
Go ahead.
Hi, Carrie.
Yeah.
So with the PAP, let's pretend that clinic's been with ASAP for a couple years, and they set up these maneuvers, and they would say PAPs, but exclude colonoscopies. I'm pretty sure the colonoscopy clinic are aware, and they're doing their part. They're overriding if they're still sending letters and stuff to people who maybe had a PAP before they were 21 and had aspirates or something like that. So they're still keeping in touch with those patients, I'm assuming, right?
Yeah. So the advice is that you would do it every 3 years from when it was originally the screening initiated. So if it was prior to what we recommend now, that it's still every 3 years after that.
So, for example, an 18-year-old had a PAP because she was sexually active, came back high grade or something. Colposcopy clinic followed her up for 2 to 3 years, dismissed her. She's 20 now, let's just say. So now she doesn't need another PAP till she's 25, or the colonoscopy clinic will advise her on what they say.
What the guidelines say is it says do initiate screening 3 years after the first sexual activity or at age 25, whichever is later. That's for the normal asymptomatic woman. But for those that have had symptoms, there's quite a few, as I was mentioning from the previous question, a lot of finessing depending on your age range after you've had an atypical. But in general, they take care of that atypical. So under 24 years, they do it every 12 months for 2 years, so 2 tests until it becomes negative, and then you return to routine screening, which is every 3 years. So if you have, there's quite a bit of finessing in there. So I always use the Toward Optimized Practice cervical cancer screening summary. It's a 2-pager, and I always just keep it in my binder to make sure that I'm correct in the advice.
Yeah, I think some of my doctors are confused because they've had previous patients who had PAPs at, say, 17, 18.
Yeah.
but they don't know whether to go with the rules I've set up with, say, Wolf, or whether to go with colposcopy clinics recommendation.
So your question is interesting, and I will share this with the whole group that's on the line. It starts to get a little bit blurry. When we talk about ASAP, we're talking about people who are asymptomatic, sort of your normal group, and that's the intervals for people who are just your normal asymptomatic in any one of those areas, not just PAP. When somebody gets a diagnosis, let's say they have a diagnosis of dyslipidemia or diabetes, of course those intervals change. You're no longer screening, you're now into management. And so your question is the same. When it comes to PAP, there's a screening age and interval, and then when something becomes abnormal or you get a diagnosis, now you're into management, and that's when intervals start to change. But the key is, once they come back to normal PAPs and they're released back because of their normal PAPs, they go into regular every 3 year, and it gives you really good advice on PAPs, on when back into the regular. Yeah, so it is a bit tricky and is for every maneuver, and I have this conversation with physicians and teams quite a bit because those lines get a bit blurred. So ASAP is for your asymptomatic, normal, you're just screening the population, and then all of a sudden you find someone who's positive for something, or they get a diagnosis, your intervals start to change because you're into the management piece. PAP is an interesting one because you can get bumped back into that asymptomatic grouping and go back into that normal screening rate again. So it's very well outlined. I really do like this, and I always use it as my cheat sheet.
Okay. So ASAP should maybe be changed to ASSAP.
Oh, tell me more. What is it?
Alberta Asymptomatic Screening Intervention.
Yeah, we need more acronyms. I like that suggestion. Does that make sense to the group? Oh, excellent. So pleased, and thank you for the question, as always. Any other questions? Well, I want to thank you. You guys have 15 minutes to go to the bathroom, eat your lunch. Such luxuries. My goodness, hey? Thank you to all who joined, and if you do feel shy about asking a question, feel free to reach out to your improvement advisors. You know them and love them, and we're happy to help. So thank you, and have a happy day for the rest of the afternoon.
Thanks, everyone.
Thanks.
Thanks, everyone.
Bye.
Bye. Bye.